কিন্তু একটা প্রবলেম স্ক্রিনিং করি not talking of these your insurance premium goes up because you are carrying a gene so you cannot be entitled for this কিন্তু আমরা যে স্ক্রিন করছি তাতে সেটা হয়তো insurance যেটা মানে আছে এই ডিজিজ রিলেটেড কভার করতে so screening has got majority advantage but from insurance point of view স্ক্রিন করে অনেক সময় প্রবলেম আমি ওদেরকে বোঝালাম যে দেখো আর আমি স্ক্রিন করে দিতে পারি বেতার অবধি নাও but the problem will be এটা তোমাকে চিরকাল নিজের মধ্যেই রাখতে হবে ওদের কোম্পানি হবে and that's what they do because if you have a congenital hydrocele or hernia even the Swasthya Sathi doesn't cover that because it is congenital Swasthya Sathi ও cover করে না hydrocele and hernia তো সেই জন্য স্ক্রিনিং হ্যাজ অ্যান অ্যাডভান্টেজ বাট আমরা যে দ্যাট নট ডিপেন্ড দ্য সাইড I want to share after assessment. शुरू करने में बोल
স্ক্রিনিং আমরা তখনই করবো যদি আমাদের ইনসিডেন্স বেশি হয় তারপরে তো সেই ডায়াগনোসিস এন্ড ট্রিটমেন্ট and third is very important in our country is cost effective so amra at ICH that being a very different cost effective the fourth one is the method the screening method that should be acceptable to the parents and you must Panjan already has told them like short for a drop of blood so these are the four important aspects these are now infant mortality in India we are after it. So every year it is decreasing to the tune of 3 to 4%. And the present 2023 data is 26.6 per thousand live birth. Major cause key prematurity, birth asphyxia, infection. We are in the third world. We have a very huge fear of infection. But once we are focusing on all these three factors, what is coming up? Coming up is the mental effects, coming up is genetic disorders, and this people. So now our focus is the perceived need that our focus should shift from the common diseases to the rare diseases. So congenital defect, including the heart defect, paroxysmal simple screening for everything, and ECMO is more or less widely available nowadays. So we should screen for that once we get and screening abnormally blood. And then we should see for the genetic and metabolic disorders because though they are rare, if you cannot detect it early, some of the preventable causes like cerebral and congenital hypothyroidism, parathyroidism. In today's case, we will present a case which, if we could have, when actually the baby came very late first. So if you could have diagnosed it earlier, the mortality. So mortality and morbidity both due to present করার জন্য আমাদের এই rare disorders গুলো screen করতে শুরু করতে হবে and not only in ICU in ICU we screen also for a long time but we want to know babies that every baby should be screened for this common disorder so that we can the preventable causes so that's like
just a platform using madam যেরকম বললেন যে we are screening so screening normally when we are actually trying to screen the asymptomatic কিন্তু যখন NICU বাচ্চা আছে মানে আমি এরকম বলি we give too much attention to infection sepsis but in metabolic disorders sepsis not present so অনেক সময় if we don't find the infection cause and when a normal clinical routine cause become a present, it's essential that we look at it. আমরা বলছি rare diseases are rare, but taking together none of these rare diseases are rare. And especially এখন আমরা এটা আমাদের government support করছে for these metabolic disorders. যদি আজকে আমার একটা liver transplant লাগে, renal transplant লাগে, there is RDN, there is a policy which is there from where we can get money. There is a one-time lakh rupees thing that we can get for metabolic disorders, এগুলো rare diseases disorders এর মধ্যে এগুলো এগুলোর কিছু supplements আছে. See, all diseases, it might not be curable, but most of these interventions are preventable. There are supplements available, and যদি আমরা সেই supplements রাখি তাহলে crisis prevent করা যায়.
And you have to support, start this very early in life.
And if you
Because
don't,
once damage is done, you cannot do much.
it is a system. আমার মেশিন খারাপ হয়ে যায়, আমি মেশিনটাকে আবার ঠিক করতে পারবো না, স্পেশালি ব্রেন। কিন্তু যদি আমি মেশিন খারাপ হওয়ার আগে ধরতে পারি, তাহলে কিন্তু আমি মেশিনটা খারাপ হবে। It's a very simple way of doing it. The other part is আমাদের খুব তাড়াতাড়ি বাচ্চা হবে, 6 মাসের মধ্যে আরেকটা বাচ্চা হবে। These are genetic disorders. If you detect it early, the second child can also be detected. I mean, Professor, I just asked Professor Anand to say times and then.
Thank you very much. Sorry, I cannot speak in Bengali. If you allow me to speak in English, I can speak the whole way because I have been specializing in this area. I don't know where to start because my clinicians or I see the babies and so one small thing I would like to add that diseases like some children like diabetes or kidney disease, liver disease, how do you detect it? Because you have to do it repeatedly. Like once in 3 months, once in 6 months, or every year. You have to do the test repeatedly. But in the case of genetic disorders, yes, some of them are expensive tests, I agree. But the life of it, yes, you need to do it just one time. Yes, at the time of birth, if you can do it, these disorders can be detected at what is called newborn screening. So just do it one time at the time of birth, 24 hours, and then you can know that whether these disorders are present or not. So, but then what's the problem? The problems again like the insurance issues and all which complicate that, and also the impact on the family. The cost also is there. Otherwise, the impact on the family, like if you have a genetic disorders, the general concept is that nothing can be done for the child. So the parents are faced with that. What will we do with the child? Should we continue with the child like that? People say. These are the false concepts, I should say. Some of these disorders are treatable. That is a message we have to give to the public. And I have talked about this in previous occasions, like how can we convince the public? Because now doctors, it's very difficult to reach out to the media. We have patients like this. We should probably also take the help of movie stars because everywhere now the movie stars are shining. So Shah Rukh Khan can support this kind of movement. Probably can have a greater impact than some of us speaking. So maybe we should also consider inviting Shah Rukh Khan to this function and asking him to support the cause of newborn screening. So, but this is actually what is the impact? Like once in the lifetime of the child, once in the lifetime of the individual, you can do that. You can say genetic disorders rule out. You don't have to do it again. The lifetime of that. That's the only
This last 2 words I want to add. I'm the adjunct professor of biochemistry. So ICH is a dedicated pediatric hospital. And in biochemistry, we have started screening these newborn screening tests, which is open to all children. And so formally, we are launching this newborn screening program today. And I would like the press to please carry this message forward that ICH is really committed to this cause of rare diseases. And just to even to highlight that all babies can come here and do the screening at very reasonable cost. So I would really, with my heart, bottom of my heart, would like to thank the press for coming today. And now we will move on to the formal program, the academic program that we have with us. Thank you so much. I will request the PGTs to call all your, colleagues and friends to come and join us. So we'll be starting the academic program is past 11:30. Ma'am, Dr. Ma'am, if you can call your, okay. So, very good morning to everybody. Okay, so a very good morning, everybody. Not only are we meeting physically, but we also have friends and colleagues online through this webinar program. I welcome everybody to this newborn screening awareness program. Now, you all know that June 28th is celebrated as the newborn screening day. And to mark this event, we in ICH have organized this particular awareness program today. I hope all of you present here take back home pearls of wisdom on NBS and help spread the awareness on inborns and errors of metabolism. Very quickly, I just want to place my thoughts before we move on to the keynote lecture today. So in 2002, Ishwar Chandra Verma, who is known as the father of genetics of India, came up with this prevalence of IM as 1 in 2,497 newborns in India. Which, if we look at the present birth rate, we see that almost 10,000 babies every year are born with some kind of IM disorder. Okay, but to this august audience, I did not need to assert the importance of this screening test. But sadly, just to tell you all that even though today, when we stand in 2023, India is still not covered by the implementation of a national NBS program. The government has taken many steps. ICMR has come forward. And we have a few DBT, under DBT, some Nidan Kendras are there. And in Kolkata, this is the NRS Medical College and Hospital. We have friends from NRS who are here. We are also a collaborator for this DBT Nidan project, where screening of such metabolic disorders and rare diseases are going on. If we look at the prevalence of the IM in West Bengal, there is hardly any data. There is just one paper which has been published on IM regarding its prevalence. And if we look at ICH experience, because we were initially outsourcing these screening tests, so over a period of about more than 10 years, we see that 2,310 sick babies, that means babies who were admitted in the NICU were screened, out of which 64 turned out to be screen positive. So if we convert that to a more comfortable figure, out of every 100 babies, we saw 3 had to be positive regarding the screening. So that's also quite a number, and therefore we'll have to consider screening very seriously. Now, to do with this, the Department of Biochemistry, Genetics, and the Neonatal Intensive Care, we came together and we thought of having this awareness program today, especially to mark the month of June being the the NBS day when June 20th is celebrated. So we came forward and we wanted to formally launch our basic in-house screening of the newborns for the inborn metabolic disorders in the Department of Biochemistry. So what we are offering right now are the 4 basic tests which are written here through the dried blood spots, and they are very reasonable rates that we are giving at ICH. And we will also be screening all the OPD patients. So after the patients have been screened, those who are positive will be followed up genetically. Dr. Deepanjana Datta is there with the Department of Genetics, and of course our neonatal intensivist heading by Dr. Kiya Ghosh Uttam. So we all 3 departments will take a full-fledged role in having this NBS drive in ICH and carry it forward. So with this, I would like to move on to a keynote lecture today, which is going to be given by Professor Kannan Vaidyanathan. To introduce our keynote speaker to the audience today, Dr. Kannan Vaidyanathan has done his MD in biochemistry, and he is a fellow of the Royal College of Physicians of Edinburgh. Presently, he is a professor and head of the Believers Church Medical College Hospital, which is in Tiruvalla. He is a member of many important international organizations. But just to mention the very important one, he is the task force member of IFCC, which is the International Federation of Clinical Chemistry. That's an international organization which is looking into the challenges of global newborn screening. He's a member of that and he's contributing very highly to this task force. And he has vast experience in this particular field of inborn errors of metabolism. He has various other research interests, and he has published quite a few publications in this field, and also he has more than 85 publications to his credit. And more importantly, he has also co-authored 3 textbooks in medical biochemistry. I think all our PGTs and everybody who's in medicine will know the Vasudevan's textbook of medical biochemistry. So Professor Kannan has been a co-author of that. So with this introduction, may I now invite Professor Kannan to the stage to deliver his keynote address, which is NBS, the way forward. Dr. Kannan. Sure.
Thank you very much, Dr. Silva, for the introduction and for your kind invitation. So it's really been a pleasure to come over to ICH Calcutta, the oldest pediatric hospital in India. And it's all even more privileging because my mother was a neonatologist practicing in another ICH in Kottayam. And the institute reminds me of this institute. It's also a government institute. It's a government institute, so even looking similar to CS. So, with everybody's permission, I'll just give this brief presentation. Like I was telling before during first meet, if you ask me to talk about newborn screening, I'll not stop. So I'll try to confine myself within the limited space of 25 to 30 minutes. So what I'll be discussing today, the title has been tentatively given as newborn screening the way forward. Since we are having the inauguration today, so I thought I'll discuss how can we carry it forward. So before that, of course, before I go to the way forward, of course, I had to give like a brief picture of where we are today. What is my role? How can I talk about screening? I will share some of the experiences because Madam told me to give some interesting cases. So some of these data which I am going to present today are published data, so please don't share it. I will request Madam also not to share the presentation. So if you look at newborn screening the world over, globally, it is mandatory in many parts of the world. Like for example, in US, there is no choice. If a child is born, it has to be screened in many states of the US. It's mandatory, and the number of disorders varies according to the state. Some states may have something like 50 disorders being screened in the US, while some other states may have 30 disorders. But the national mandate in US is that screening is mandate. And it was introduced way back the 1960s. That means we are, of course, lagging behind. And it was based on the ACMG recommendation, which the screening was introduced. Now, in different countries in the West, also the number of disorders screened vary. If you look at Europe, like in Germany, only 12 disorders are screened. In UK, maybe only 2 are mandatorily screened. Well, some others, it doesn't mean that screening is not going on. But from the government perspective, mandatory screening in France and Hong Kong maybe only just hypothyroidism is screening for. So doesn't mean that mandatorily we had to screen all the disorder. That's the first message I want. Just so to, like we were discussing before, that congenital hypothyroidism is very common in India or Bengal. So if you can say that we are screening all individuals for congenital hypothyroidism, we can very well say that screening is officially going on in India, but right now we are not yet at that stage due to different reasons we'll come to. Now, aminoacidureas, some people say it is not common, so you don't need to screen. But in countries like England or Ireland or even Austria, some European countries, it's mandatory screening. And fatty acid oxidation disorders, some of the organic acidureas, in fact, they are pretty common in India, but it's mandatory screened in countries like USA and Australia, etc. And there are various other disorders in nephropathies and the hearing defects and lots of other disorders which I mentioned here, cystic fibrosis, which are differently screened in different parts of the world. Duchenne muscular dystrophy, was talking screened in some parts of the world. So, this was the status of India in the beginning of the millennium. Madam was talking about Professor I.C. Verma, the great geneticist from India. This was a famous paper which was called publication of I.C. Verma called the Burden Bill. It was a burden to those who were, to the government, because he openly lashed out at the government even in the millennium, because he said that the burden of genetic disorders is very much indicated these disorders very carefully. So this was published. Another similar paper was published also in the Indian Pediatrics Journal. But after 20 years, this is what he said again about the burden of genetic disorders. In 2020, he lashed out this time at the newspaper report saying that the government is doing nothing for genetic disorders. So, because of many of his efforts, he is considered many people consider him as a father of genetics in India. The government has come up with various schemes, like for example, the multi-centric study by ICMR has come. The various Nidan Kendras were started in different parts of India, and so many things have come. But still, newborn screening is not mandatorily introduced. That doesn't mean that it is not going on. For example, in my own state of Kerala, there was a report which came pre-COVID times that newborn screening is going to be mandated. There are some institutions in the government sector in Kerala where it is mandatory done. For some disorders, like again, as I told in the beginning, it's not necessary that all disorders need to be screened. Like hypothyroidism, CAS, etc. were screened for in India, but in Kerala, but that too in the government sector. And it was published before the pre-COVID time that newborn screening will be made mandatory, but sadly COVID came and emphasis everything changed after. So still that's not been implemented. So that's the state in India. So what's the problem? We are faced with so many challenges. If you look at the health sector alone, the government has so many challenges, and we have various reasons for infant mortality which are currently there for infections, as Madam was telling. So the government's priority is first to look at these, but still not far behind is genetic disorders. And if we ignore genetic disorders, what is going to happen is that we are faced with 1 in 2,000 live births. So how much is it going up to the population? So that many children are going to be born every day. So many children are getting born with these genetic disorders, and they are adding to, as Professor I.C. Verma was telling, to the burden to the society. And these are burdens which, if prevented, can be, if diagnosed, as I told during the first meeting, you just need to do this just once in the life of a human. You don't need to do it every month. You don't need to do it every year. Just need to do it once in the life of the individual at the time of 24 hours after birth, and you are assured that you can give him the tick mark. Otherwise, you just do the treatment for that. And like other children are fine. So you just need to do that once, and that is where our government is facing problem with the funds, etc. So that is the current state of inborn genetic disorders or inborn metabolic disorders. In the West, they call it inborn metabolic disorder. We call it inborn errors of metabolism. They don't use the term error. They call it inborn metabolic disorders. So this is what we did. This is my experience with inborn metabolic disorders in the previous institution we have worked. ICH is starting now. We started some time back, and I was fortunate at that time to join that lab. Where already some work was going. So I was doing my postdoctoral fellowship at the Institute of Science when the call came from the Institute of Medical Science to join the program. So we screened for many of these disorders, and I'm not going into too much details, but this is what we found. We found a large number of cases of amino acidureas, organic acidureas, or homocystic disorders, pheochromocytomas, and elevated adenosine deaminase deficiency, some of which are due to genetic causes, some of them acquired causes, and also congenital adrenal hyperplasia. I'm not showing the data on hypothyroidism because thyroid was done using a different technique in a different lab at that time in Amsterdam hospital. So, but we also had lots of cases of thyroid disorder just to complete the list of disorders, and of course D6PD also, which was also done the clinical biochemistry lab. Now, just so that just to show you that genetic disorders are pretty common that population. Now, the patients came from different parts of Kerala, like mostly from North Kerala, where there's a lot of consanguineous marriage. Like, for example, this particular person. It was a 21-year-old lady with subnormal intelligence who was suspected to have phenylketonuria, came from a hospital in the Kozhikode, that's the North Kerala area. And when we did the investigation, that's the phenylalanine level. Normal level, is about 100 micromole per liter. And this lady had a very high phenylalanine level. So, which is suspicious of phenylketonuria. At that time, we didn't have facilities for genetic screening. But later on, further investigations were that this was done by HPLC. And further investigations proved, in fact, that the lady had phenylketonuria. And what was the sad aspect? Why is it important? Because the lady was pregnant at that time. And in spite of advice, that we advise that if you can, even during pregnancy, you can reduce with the dietary restriction, you can bring down the phenylalanine level, but they didn't follow the advice and the child died by a condition of maternal hyperphenylalanine. Pediatricians would know that. So the child died. So that was the sad picture. So if they had given that advice, or even during pregnancy, if they had control of phenylalanine, probably they would have had a child normally born to them. The story didn't stop there. The lady had a younger sibling, a 19-year-old sister of the previous lady. So the doctors convinced her to do the phenylalanine level for that for her sister, and that's the phenylalanine level for that lady, 1,000, which is suspected of phenylketonuria. And she was going to get married. So we advised her, please control the phenylalanine level. And they also didn't control the phenylalanine. They also had a child who was born with phenylalanine. So again, that is a story, a sad story of a family with two sisters with phenylketonuria, and both of them having children with phenylketonuria, which could have been properly controlled. And what was needed was, if newborn screening was needed, and the second one was compliance and to the treatment as well. Now, I'll shift gears. This is a third case that I'm showing. This is a child with irritable, excessive irritability, abnormal posturing since birth, delayed developmental milestone, a history of sibling death. First child died at day 15 of life. As all clinicians know here, if you have a first child born died due to unknown cause, and you always suspect genetic disorder for, especially when there is no history. So the pediatrician had a strong suspicion of MSUD, isovaleric acidura, phenylketonuria, or some genetic disorder. She had a notion. And when we did the HPLC aminogram, we found elevated levels of varying isoleucine and leucine. Now, for this child, we came immediately after birth. First child died at day 15, and this child came immediately after birth, and the treatment was initiated. And your MSUD treatment is not easy, so the treatment was initiated, and sorry, and no, I don't have that figure. And afterwards, when we did the phenylalanine, the 3 amino acid level came down. But since we are from the lab, we don't have the long-term follow-up. But at least during the immediate postnatal period, the child survived because we were able to detect the child the case at an early stage. Probably later on, whether they comply to treatment, etc., we don't have data. But at least during the immediate postnatal period, the child was able to be discharged from the hospital with the child levels being normalized. This is like another case, 12-day-old child with metabolic acidosis, ketonuria, abdominal urine order, and hepatosplenomegaly, little late, but again the levels of phenyl, the 3 amino acids are elevated, but probably because it came later during on the 12th day of after delivery, we were not able to save that child. So the first child was detected at birth and this was day 12. So again, highlighting the importance of newborn screening because newborn screening is normally done 24 hours after. So if you can do it at that stage, probably you could prevent death to the child. But if you are late by even 12 days, 10 days coming to the doctor or doing the investigation, the only difference is life and death difference. So this one, yeah, I have the figure here. So this one treatment you can see two amino acids are this. I don't have the graph here. Actually, the level has come down to about 300 from about 2000. The value has come down to 300 whereas valine and isoleucine levels have come down to normal. Only leucine levels are elevated. So that's the impact of early diagnosis and treatment in the case of genetic disorders. Now there's another child, a 7-day-old male child with intractable seizures, and when we found that glycine levels were elevated, and further investigations, CSF to blood glycine investigations, etc. were done, and we proved that it was due to non-ketotic hyperglycemia, which is a very difficult disease to treat, and of course, this child succumbed to. So again, highlighting that not all diseases could be saved. Some children die because depending upon the type of disorder, non-ketotic hyperglycemia doesn't have proper treatment and it's difficult. Even if you have newborn screening, it is probably difficult to prevent. And in Kerala, there are quite a number of cases of non-ketotic hyperglycemia in the in the institutions I worked afterwards also where we had detected some cases of NKH. So that due to the defect, I won't go into the detail, I think for all that, it's due to the defect of the glycine cleavage system and the ideally this diagnosis is established by a CSF2 plasma glycine concentration. But even a plasma glycine estimation can also give you clues regarding the glycine non-ketotic hyperglycemia. Now, another case, this is a case where urine screening showed presence of tyrosine and ferrichloride and other tests were also positive and thin layer tests detected tyrosine. And when we did the HPLC, the tyrosine levels are mildly elevated. Now, tyrosine, why I introduced it here, is one amino acid which is not very easy to detect. Those who in biochemistry will know tyrosine is you need some other investigations by what is known as a second tier testing for newborn screening like succinate acetone, which is a better indicator of tyrosine because urine screening or even blood investigation. But the problem is there are some other molecules which induce co-indute, but technically it is called co-induting. Co-indute tyrosine and it will confuse the diagnosis. So sometimes you can pick up or you can miss or you can pick up wrong cases. So tyrosine is something which is not very easy to detect by conventional methods. So succinate acetone has shared this light because of that particular aspect here. Now there are lots of, you know that very well, lots of these kind of screening tests, like you could do even the color test, which we used to teach to medical students earlier on. The color reactions of amino acids was very fondly called the different. We can now show it on a next exhibition or something. But this is, for example, the hidden Myrmecosporidia urine screening test. But unfortunately, these tests lack specificity or sensitivity. And therefore, currently, that way, we used to do many of these investigations, I should confess at this stage. But in the present world, they don't have any relevance. Of course, it will give you if it is it is positive, but still you can miss cases and also misdiagnose cases, so they don't have much relevance. And especially if you're looking from an academic point of view, they have no relevance because you say that you have done your screen using urine and you won't even be able to publish it in a local journal. So that's the current situation because they are being outdated. So urine screening doesn't have any relevance in the current world. So now another example of a urine screening test sometimes, but even though it may not be helpful academically, it can help you in medical context. So that is why many people do that. But I already told you the good and bad of it is lack of sensitivity and specificity. Now this is, I'll leave the entire history, but this is a urine testing which is positive for homogenetic acid. How do you do that? Bendix says you get the black color and the black and the urine which becomes black from standing, which you see on the textbooks. So this was, there are some other units screening test. This is of course the Bendix says you have a test called the ammoniac and silver nitrate test. It's simple. You just add some ammonia to the urine and just drop silver nitrate. The urine will turn black. It's like essentially it's just oxidation of urine which is happening with the help of the silver nitrate. And this is actually case of anybody, any guesses? Alkaptonuria, that's right. And this is the blackening of the diaper, which also was seen in that particular case. So of course, it doesn't have sensitivity, specificity, etc. But from a clinical point of view, it can help you to detect cases. And because it's very alarming to the patient, these the parents came with great alarm because the blackening of black urine, etc., can be alarming. Essentially, we all know it's now very dangerous, but still current reports say that by about the third or fourth decade, it can be crippling. But unfortunately, there is no, there can be joint pain, etc., which can be quite bad to the patient. But unfortunately, we can't do much for alkaptonuria currently. So alkaptonuria, as well as the other disorder which I showed, propionic aciduria, methylmalonic aciduria, you don't need to do all these tests only, but there is a simple flow chart which you can help use to from a clinical context and some using some just some little bit reasoning and basic biochemical testing like ammonia and blood gas analysis, electrolytes and urine ketones, you can detect organic acid. For example, if you have no metabolic acidosis, it is to it shows with hyperammonemia metabolic acidosis, it is more an indicator of organic acidosis. Metabolic alkalosis is an indicator of urea cycle disorder. So the two major differential diagnoses when you have hyperammonemia, urea cycle disorders and organic aciduria. And further investigations using some of these urine screening tests can help you to get to even a differential diagnosis of which type of urea cycle disorder or what type of organic aciduria, etc. it can possible to diagnose. So we can develop many of these algorithms or flow charts, for example, in the case of organic aciduria and various other clinical disorder, genetic disorders, where we can come to a clinical judgment of the type of disorders. So I won't talk more about genetic disorders because I think there's a genetist is going to come, going to speak here. But we have also done some amount of genetic disorder screening, for example, for Duchenne muscular dystrophy, which is pretty common, spinal muscular atrophy, and the XBB gene sequencing we have done. And this was by the MLPA technique of sequencing. This was a manual sequencing with MLPA. And we were able to detect some of these kinds of genetic disorders as well in our population. And some other rare genetic disorders were also seen, including we did some, just for academic purpose, we did some studies on congenital adrenal hyperplasia. So genetic disorders you can do by this kind of genetic techniques as well. So I think I'm well within time. The next 10 minutes, I'll now try to wind up with the summary and the IFCC and SSIEM recommendations. So when should you do the different tests? That is the current thing because everybody is asking, at least on the genetic biochemical audience when I'm going, these are the things which people ask me. So when do I do the urine metabolic screening? Like I told you just now, it is not recommended. So urine metabolic screening may sometimes be of benefit from a clinical perspective, but if you're looking at academic, trying to publish, or if you are a postgraduate student trying to do your publish, urine metabolic screening is out. Internationally, it is nowhere in the picture, so it is completely out of this. It was a historic test. Now you can do this ELISA, or what technically it is called as a Delphia technique for biochemical screening for congenital adrenal hyperplasia, CA, CH, GALT, D6PD, and PA. So what I want to emphasize is that not every test needs your tandem mass spectrometry. Tandem mass spectrometry, as you know, it needs a lot of investment, like 1 crore or something. So it is not feasible for all institutions to do that. But suppose you want to screen for the other these 5 disorders, your Delphia, which is available for even a few lakhs, this can be done. You don't need to invest that much. Even with an ELISA, the Kerala government was doing these disorder screening. So it is possible to do with many disorder screening even without a tandem mass spectrometry. Of course, for other disorders, tandem mass spectrometry is preferred method. There are also other methods like ECMS is there. You also have NMR spectroscopy which is available. But the tandem mass spectrometry is the preferred method for the other disorders. But what is the problem with tandem mass spectrometry? To be feasible, you need at least 100 samples a day, roughly. Even if you have 30 samples a day, cannot be cost effective for you in the long run. So if you can get 100 samples per day, you can safely start with tandem mass spectrometry. No, don't need to think back. It doesn't need to be from your own institution. If you can get from like Bengal, if you're getting from other parts of Calcutta, if you can reach that golden figure of 100, you can definitely go ahead plan for work with tandem mass spectrometry. Of course, there can be minor differences because in the long run, otherwise it will not be cost effective. Long run, you can do a lot of samples in one run itself. So if you can start with 100 samples in the beginning of the day, by the end of the day, you can get the results to that. Other techniques are there, HPLC, GCMS, NMR. They can be done, I hope not recommended, but under special circumstances it can be done. But if you're looking at general screening methods, these are not recommended for newborn screening as in specific tests it can be done. It can be controversial, I can see discussions going on. We have also done using HPLC, that is why I wrote that here. It is not recommended for general newborn screening. Specific disorders, of course, you can still continue to use that. Second tier testing and molecular testing are need based, depending upon the circumstances, what type of lab you are you a referral lab, are you on the basal level, depending on those circumstances, you can start the second tier and molecular testing, not recommended at a for all the laboratories. So these are this of course the IFCC still hasn't come up with the recommendations. Also only just like at a personal level, these are recommended, but these are from the from what our discussions are going. This is the recommendation which are coming up. So what is the current status of newborn screening? How should we do it? If you ask me, do it right the first time. So internationally, that is possible. They tell if you want to do it in the right way. But whether it is possible in the Indian circumstances, like I told you, we have pressing clinical needs at many times. But if you ask any international expert what he thinks, whether you should start newborn screening or not, he will tell this. Do it right the first time. That is, if you have to do, you start with tandem mass spectrometry or Delphi or something. Don't start with dabbling around with urine screening. But many times what we know is that the clinical situation will force us to start some of the other methods. But as far as possible, at least I thought I'll share this. This is what the IFCC says, do it right the first time. So screening is going on in different parts of the world. Like I personally feel am involved, as Madam was studying with the data of the global screening process. We have been now trying to promote screening in African countries, Latin American countries, even some European countries. You might be surprised that not all countries in Europe are screening the right way. You know that Europe doesn't mean every country is rich. There are very poor countries in Europe where no screening is going on. So they're also trying to promote some screening in some of these underdeveloped European countries, even though it might sound like odd to say. And also in various Asian countries, including Nepal and Philippines, etc. I personally am be going to some of the African countries in the next year, trying to talk and promote the newborn screening program in some of those countries. Of course, they have a lot of interest. Nigeria and various other countries have lots of interest in newborn screening. Now, and just take 2 minutes. What about India? I have not talked about India. Now, we all know that in India there is a lot of motivation. Biochemists are highly motivated in India. So, for India, I wrote like very bold letters. This is the message. We all do newborn screening in many parts of India. If you look at any biochemist, if you ask for career options after MD, say, are you interested in newborn screening? I don't think any biochemist would say he's not interested. Almost everybody wants to get interested. So the only message is this one. For the future, if you are trying to make a career in newborn screening, do it right the first time. Because in many parts of India, it's going on, like Madam is starting also here. Many places are trying to start newborn screening. So do it right the first time is the only message I would like to give. So with that, I'll be happy to take any questions. Thank you.
We'll do it at the end. So, it's a bit relevant. Suppose we have a very critical way, yet we cannot start the field. So, what's the chance of getting false negative results or get the child will be sent down?
There is a high chance. Actually, ideally speaking, the newborn panel, as I call it, should be done fasting. But the problem is many times in the case of babies, newborn babies, it's not possible. Now, for example, like amino acids can be can vary with feeds. If you have temperature, if you say red tell, do it in a fasting state. Now, what we used to do, I'll tell you that. What we used to do, we just used to, if it is babies, it is almost accepted because you can't control feed. But what you need to do, what you can do probably is that you can mention whether it is fasting or after food. So that you leave it with a caution to the clinician to interpret with caution. Because now let me tell you, the variation is not very significant. Like for example, I showed you the value of 1000 for phenylketonuria. With feed, you are not going to get that much difference. Maybe you will get a difference of 10 micrograms per liter, which will not complicate your clinical picture. If you're looking for publication of whether you say it is after feeds or not after feeds, whether it is fasting or non-fasting. But clinically, it will not have a relevance. Yes, clinically, there are situations where relevance is there. For example, ammonia estimation. Now, ammonia, you know, is a degradative product of amino acids, and if it is before feeds and after feeds, sometimes your hyperammonemia may run into a problem. So in such situations, ideally it is better to have a fasting cycle. Now again, the same applies to another question. Another thing which will come with that is whether how long you can store the sample. Because in the case of amino acids also, when you are storing for longer time, the amino acids will degrade and your ammonia level will go. It's the same thing when you're doing the feed also, because post absorptive also, the same thing happens, your amino acids increase, and when your system is in bad, like for example, you have a permanent liver failure, etc., your hyperammonemia can shoot up like it. Now, related to that, another thing we can tell from experience, practical experience, we see many situations where many amino acids are elevated. So it's many times a challenge to clinicians to interpret it as well. Usually what happens is that this is a sign of liver failure, especially in neonate. Because why? It's not a genetic disorder as such, but when you have liver failure and the liver is unable to metabolize, and especially if it is after feed, all your amino acids are going to be broken down and you get hyperammonemia, all these amino acids. So that's what they say.
So if we give amino acids by parenteral nutrition, so
Yeah.
then it's going to alter
Yeah,
the.
it can.
So ideally, if you think of any amino acid.
If at least before infusion, if you can, amino acid infusion, if you can give that would be recommended.
But if I am giving an amino acid infusion and we are thinking some amino acid disorders, so results will vary. So if there is any manipulation, any gap.
But
after
again, in your research, you had to mention whether it is after infusion or something. But again, as I told, it will not be like the same level as your phenylketonuria 1000 levels or something. Maybe if after amino acid infusion, the levels will be higher than after feeds. Maybe it will be 10, 20 or 30, 50 up to can be elevated. But still, it will not complicate your diagnosis of genetic disorder usually. But what can complicate is your ammonia. Ammonia can be a complicated factor. Ammonia can shoot up like anything.
So to conclude, if it's suspecting IEM,
Ideally
we
fasting.
can
Ideally
send
fasting. But again, now there's another thing. If you're looking at, if you want to look for like hypoglycemia, postprandial hypoglycemia, obviously if you are taking fasting, it will not help. So for example, if you want to check for postprandial hypoglycemia, you have to take it postprandial. So that depends on very much depends on the context as what you want to detect. But for general panel, if as far as possible, make it fasting. If you can't make it fasting, make a mention whether what is the kind of feed, and in your interpretation, tell that interpret with caution with the clinical picture.
in hours of fasting, any
It doesn't help for children. Infants, it won't help.
So my question is, if children are going, what about their diet? Because we really find it difficult for the nutritionists to guide us.
Right. Now, special feeds many times are not available in India, but there are a few families which can afford special feeds now. Now, I heard that in future, in the coming years, there are going to be organizations that will make these special feeds available in India.
Yes,
Madam
actually,
can-
there is right now a trust which is called the Sheetal Foundation Trust, which is actually sponsoring IDM diets. So if you have any child who is not being able to afford, then reach out to me. We are the NGO is present in Bombay, but we are sponsoring for everyone, anybody who needs it. Anybody who needs it, they can approach, and they are giving us quite a bit of support. Trying to
More
provide
organizations
sponsors.
will come up in future years also.
So there is the IEM Trust, which is along with the Indian SSIEM Society. So they are actually doing. And if you have any patients, let me know. We can put them on a lot. They're giving on a lottery basis, like some per month. But then most of them are getting.
We will be felicitating Professor Vaidyanathan. I request Dr. Shubha Basu to request Dr. Joy Roy to please provide the opening. I request Dr. Rito sir to please provide the small gifts which we are providing. Request Dr. Priyakar to provide the speaker trophy.
Anyway. NBS. NBS. we we had a wonderful lecture from Professor Vaidyanathan. Now, I'll present some clinic scenarios which we very often face in the clinic. And when we talk about newborn screening, as it's a screening technology, you also have to understand that it has its own limitations. So when we are screening here, I will talk about these challenges that we actually face in the clinic. So here is a child who was delivered at term. It's a male, 32-year, born to a 32-year-old woman. Birth weight is fine. If the baby had a bit of physiological jaundice, but improved and had mild icterus, but was screened for the 7 conditions and was positive for biotinidase deficiency. Now, if the baby was positive for biotinidase deficiency, so now the normal thing is that we need a second screen after 14 days. So that is what the protocol is. When we did the second screen was actually negative and it came borderline. Now, understand if this you are a parent and you see this report, the amount of psychological anxiety you go through. So this is exactly where, when you are doing newborn screening, we also need to emphasize the fact that this is a screening technique and what is the aftermath, like what happens when the reports come, and also look at the child as well, whether the child is showing actual symptoms for this. So now, if you look at this is basically in any test, we will have true positive, false positive, false negative, and true negative. Just to be like extending that, here is another child with 2.5 months, female child, third degree consanguinity present, has a history of interactable convulsions, failure to thrive, but has no family history. There is hair fall almost looking like alopecia and skin lesions. Now, when we screen this baby, obviously the lactate, the ketones were sort of not very informative, but the serum lactate was a bit raised. And the TMS had an elevated C5OH. The acyl carnitine, total carnitine, and the serum biotinidase were aberrant. Now we look at it, this child obviously was fitting into the biotinidase deficiency. A simple supplement improved the child after 3 to 6 months. So this is the beauty of probably a newborn screening, where you see the child on the right side and child on the left side, and you can see the differences there. So basically, the effective screening, the window of the effective screening is very short. Hence, screening is extremely important. And if we can catch in the preclinical region, then we can have an effective treatment. And this is true for a lot of involved errors of metabolisms, where the treatment has to be immediate in order to prevent any kind of after effects or leave some chronic issues. Now, in India, we are a cost restrictive setup, so we try to do less tests. Again, when we do things like that, also counseling becomes very important. Why? Because you can see here another baby, and we have done a TMS in this case. And when we have done a TMS, it's elevated CPAC. Now, if I leave it over here, there is a possibility of 2 disorders we are looking at. We are looking at MMA or PA. If no further testing is done, then we still can treat this baby, but we will not know what it is. Now, there are many cases when we find, as a geneticist, I find that the screening has stopped over here. But actually, you need the second tier testing, which is the GCMS, which will actually tell you that this was a MMA. Now, is this enough? Now, if this baby ultimately did not make it, and the baby, there are managements available, but still the baby did not make it. And now the couple comes back saying that we know that the child had MMA, but can you do, and I'm carrying my next pregnancy, can you test my baby? Can you do it? We can't, right? Because in prenatal, we will not be able to do a newborn screening. So here is another child from a different case where we are actually, the previous fetus was detected with MSUD, but for detecting this particular pregnancy, we needed to do the genetic testing, and with the genetic testing, we found that this fetus was also affected. Now, how can we counsel? So basically, most of these disorders will be autosomal recessive. I don't need to imply on this group what autosomal recessive is, or it can be X-linked recessive also in certain cases of amino acid failure or organic acid weakness. But mainly, that what the bottom line is, there is chance of recurrence. So if you have a baby with a diagnosed clinical IEM, who is succumbed, who is not there, then we need to test the parents, and if we test the parents and we get a mutation, we can either do aminocentesis or CVS from 3 months of their birth, from 3 months of their pregnancy, or you can offer other kinds of reproductive options like gamete deletion, or you can offer a PGT. PGT is especially where we are actually screening the embryos. We are taking the embryo biopsy, we are screening the embryos, and the good embryo, the one healthy embryo, is put inside. Now, again, when we are looking at the reports, we should always also look at the child. So here, it basically newborn screening gave a positive report for PKU, but due to financial reasons, there was no other testing done. And the child was put on PKU diet, but the problem was the child was not improving. Just now, sir said that sometimes we see a lot of amino acids being raised. So we were thinking of our differential diagnosis. So now look at it. So that number of amino acids are raised, and in this case, when we actually did the genetic testing, we found that it was hemochromatosis, what we are looking at, and there have been sort of reports where these kind of profiles are found in the neonatal hemochromatosis we are looking at. So again, when you're looking at the newborn screening reports, also look at the differentials if the child is not improving. This is a case study which is right from this institute itself. So we had patients who were detected with MOCS. Normally, there is a therapy which is available, which is pyronopterin. Pyronopterin is extremely costly and not available in India. But I collaborated with Professor Anil Jalan, and he actually had a trial where he was using a methionine restrictive diet. And as you can see, both these children actually improved on the milestones. We lost one child to follow, but the second patient which we have is continuing with us, and this child is actually improving. So, there are other trials or other methods which are also coming up. We are a bit aware of these. Maybe we can offer them these kind of therapies to the patients. So there's a paradigm shift where earlier only sick babies were screened, only babies who were in the NICU were screened. But right now, if we can do screening earlier, we can actually have that preclinical stage and help them. So if I'm looking at genetic counseling, then at every stage it can be there. It's diagnosis, carrier testing, diet management, medical management, where the family gets a bit bewildered that they have to go to so many places, look after so because it's a multidisciplinary management. Then also the genetic counselor can have a psychosocial assessment and also transition of care, because these children will reach adolescent and be handed over to the adult medical people. So again, I will reiterate that this there's no reason to think that there is no support. There is RAN and there is rare disease policy, which is actually giving you supplements for the group 2 and surgical interventions for the group 1. There is a one-time 50 lakh available, and also a RAN scheme which actually gives you 5 lakhs for any kind of surgeries in these cases. So the concept is the newborn screening has its limitations, and we should be also open to differential diagnosis so that we can catch them pre-symptomatic and reduce the historical patients. So that is it from my side. Thank you. Questions?
Thank you, sir. So now we move on to the case studies from our own PGTs. So Dr. Ma'am will be presenting the first case study. Dr. Ma'am, over to you.
We are going to present two cases of IEL which has been past 1.5 months. And the first case that is presented by Dr. Mang is a very unfortunate case. Got a baby at 1 month, 7 days. So just go through it and you will see what is the importance of it. And it's maybe been seen in the first few days of life. The second case will be presented by Dr. Shobha, and this is also a veterinary case. So please don't go away, please stay back.
Your turn. Good afternoon, everyone. Coming straight onto my topic, the topic of my presentation is neonatal jaundice with acute renal failure. Baby of Priyanka Saroj presented to us at 1 month, 7 days of life with complaint of yellowish discoloration of the skin since the last 15 days, abdomen distension for the past 10 days, and clay-colored stool and high-colored urine. The history was provided by the mother. This 38 days old child was a firstborn of a non-consanguineous marriage, has history of jaundice for 15 days with clay-colored stool and high-colored urine, which was gradual in onset, and baby developed abdominal distension with decreased feed acceptance. Urine output was adequate. There was no history of swelling in other parts of the body. There was no history of fever, lethargy, bleeding, or any history of seizure, and weight gain was adequate. Antenatal and natal history were uneven full. The child got admitted in NICU on day 9 of life for jaundice, and the child received physiotherapy and was discharged after 3 days. On the day 20 of life, the parents again noticed discoloration of the whole body, and the child was exclusively breastfed. And on admission, the child vitals were more or less stable. The child was started on soy milk-based formula diet. And on day 3 of admission, the child's abdominal distension increased, and the child was not maintaining saturation in air and was dependent on oxygen. And there was increase in the abdominal GERD also. So for that, the child was kept NPM. And after consulting the gastroenterologist, we did a diagnostic and therapeutic ascitic test. On day 4 of admission, even after doing the ascitic test, the respiratory distress worsened and child was shifted to high flow nasal cannula. And after day 5th of admission, the child condition further deteriorated and was shifted to mechanical ventilation. And the kidney function test also increased within the last 48 hours, and child developed oliguria. And in view of the increasing oliguria, in view of the increasing creatinine and oliguria, therefore team was consulted and child was started on peritoneal dialysis. And after starting the child on peritoneal dialysis, child developed hypertension and got inotropic support. And on around day 10 of life, the child had decompensated liver failure, following which there was bleeding from multiple sides. And the child gets severe multiple transfusion of blood products, and there was no improvement in the liver function as well as the general status of the baby. Liver biopsy also was done at this stage, which shows marked cholestasis with bridging fibrosis. Some of the relevant investigations were urine-reducing substance was positive, but non-sugar reducing was positive. Urine ferric chloride was positive, which more or less must be false positive due to the increased bilirubin level. And there was a progressive increase in bilirubin and creatinine, and ultrasound KUB shows raised echogenicity of both the kidneys. So to summarize, we have a term AGA male child presented with cholestasis, which can be mainly due to metabolic cause or some which is also associated with acute liver failure, ascites, and child also developed stage 3 renal failure, and the child had a growth of Acinetobacter in bile culture. Some of the common liver causes in neonates, since the child presented to us at the 3rd week, can be HLH, hepatitis B, bile acid synthesis, or even galactosemia, fructosemia, or tyrosinemia. The worrying thing about the case is the liver failure can be explained, but the acute renal failure cannot be explained. So can the acute renal failure be due to bile gas nephropathy? So what is bile gas nephropathy? Bile gas nephropathy is mainly characterized by deterioration in the renal function due to the presence of increased bilirubin level. And this bilirubin level can lead to kidney injury through multiple mechanisms, like the toxicity itself of the bilirubin can decrease, can affect the renal tubules, as well as the bile gas can block the nephrons. And diagnosis is challenging as renal biopsy is needed for diagnosing this case. And for us also, as well as in most of the cases, renal biopsy cannot be done because of impaired coagulation profile. Urine analysis sometimes helps in this case if there is presence of bile crystals and granular gas. And the treatment modalities include percutaneous biliary drainage, albumin dialysis, and plasmapheresis. Why I'm saying the baby might have bile gas nephropathy is because of this. After admission, the child had history of passage of this kind of discharge through the urethra. So we were thinking of some fistula connecting the rectovesical fistula, but the surgical resident and the surgical consultant they told it was not there. So it can be because of this. Or can the kidney failure be because of hepatorenal syndrome? Can be. The ICA proposed a diagnostic criteria of HRS and AKI, and this criteria includes diagnosis of cirrhosis and ascites in the baby, diagnosis of AKI according to the ICA AKI criteria, on no response after 2 consecutive days of diuretic withdrawal and plasma volume expansion with albumin of 1 gram per kg body weight, absence of shock, no use of nephrotoxic drug, and no macroscopic signs of structural kidney injury. Even after doing PD, there was no improvement in the child, and the child condition further deteriorated. IEM was also sent before it, but it was negative. As the child was NPM, and after that, since we don't have any, we sent the whole exome sequencing, which shows galactosemia. So the
Just to confirm, because the child came in so late condition and deteriorated, because the first admission was in some different hospital. So we thought galactosemia on the first go only, but the report came negative. That's why I was asking sir, what is the chance of getting false negative results? And when the child was deteriorated and there was no other way for them to send the full exome sequencing, so we sent that and we got cleansed the diagnosis. Unfortunately, the baby deterioration has a very rapid deterioration. The baby, and you know the galactosemia can lead to renal failure, but most likely we search for this, and most probably this for the bilirubin cast nephropathy. So, institution of that process. So we thought of this.
Thank you. Thank you. Sunny.
Good afternoon. I'm going to present a uncommon case of neonatal encephalopathy.
স্লাইড শেয়ার করো, স্লাইড শেয়ার হয়নি, স্লাইড শো করো। হয়নি হয়নি, সুরজিৎকে ডাকো। সুরজিৎ ওই প্রসেসে করে দে বাবা, ওটাকে
ওটাতে তো করলাম।
আগে অন্যটা তাহলে শেয়ার হয়েছে। যেভাবে তোকে বললাম আর কি।
এই দুটো আপলোড করে দেবো। Hello.
হ্যাঁ ঠিক আছে, প্রসিড করো, ঠিক আছে, ওকে। ডবল ক্লিক করো, মেন স্লাইডের উপর ডবল ক্লিক করো,
কি বলছো?
স্লাইডের উপর ডবল ক্লিক করো।
ঠিক আছে,
ঠিক আছে, ঠিক আছে, ওকে ওকে।
This is a baby of AB who is outborn, single term baby, 37 plus 4-week born, and birth weight was 3.31 kilo. He was appropriate for date and cried immediately after birth. Date of birth was 24th of May this year. 5 to 6 minutes after birth, the baby turned lethargic with decreased activity and was shifted to the NICU to the outside hospital. A blood investigation done there, which revealed pH was 7.29, bicarbonate was 19, sodium was 130, potassium 6, ammonia was 227, and lactate was 8. USG brain echo was done there, it was normal. Prophylactically, they have started cefotaxime and amikacin, and he also received FFP because the baby was having GI bleed. But the baby was not having any symptomatic improvement in the encephalopathy, so the baby was shifted to ICH on day 4 of life, that is on 29th of May. Regarding the mother's history, mother is 29 years, gravided 2 para 1, and a non-consanguineous marriage. And the abortion at first trimester abortion is spontaneous abortion. Course in ICH. After admission in ICH, the baby was lethargic, cyanosed, and was in shock. He was shifted to mechanical ventilation on SIPPV mode due to poor respiratory effort and depressed sensorium. After the proper oxygenation and warming, the cyanosis and the shock resolved. The blood sugar, calcium, sodium was also normal. On examination, this is during the whole course of the ICH stay. There was no opening to pain. There was hypotonia. The deep tendon reflexes were initially absent, later became brisk. So we kept the impression of central hypotonia. Neonatal reflexes were absent, but the baby was having intermittent hiccups, which present along with myoclonic jerks. The CVS, GIT respiratory system examination was done, which was normal. We managed it like this. We changed the antibiotic to meropenem as CRP was raised. Ammonia lactate that was raised in outside hospital, it was decreased, and the urine ketone was absent. In the meantime, we sent the extended IMS screening and the whole exome sequencing. Due to seizure, the baby received phenobarbital and levetiracetam. The seizure frequency decreased and the hiccups also decreased. The baby was kept nil by mouth and the baby was extubated after 10 days because the baby regained his spontaneous respiratory force. IM screening done, we showed glycine level of 1131.98 micromole per liter. Normal range is 125 to 450. MRI brain was then done. We showed abnormal signal intensity in the bilateral basal ganglia and the periventricular region and mildly dilated ventricles. MR spectroscopy was done. We showed the large glycine peak. Along with lactate peak was also raised, but the NAA peak, which is usually normal, it is reduced. This is the glycine peak. The white one is the glycine peak, which is raised at the 3.5 ppm. This is the EEG we have done, which shows burst suppression. And the whole exome sequencing was done. This is the whole exome sequencing report, and it shows homozygous missense mutation of AMT gene of chromosome 3. That is MNSA substitution of arginine by histidine at codon 265, which is suggestive of glycine encephalopathy, and autosomal recessive. OMIM phenotype was 605899. This is the report. Now regarding the glycine is an inhibitor neurotransmitter we know, but it is excitatory in newborn. In some places of the brain, the mostly cerebral cortex, it is excitatory, whereas the brainstem, it is inhibitory. These changes at around 2 months of age, like in pediatrics and adult, we have KCC2 receptor predominates, while neonate, it is NKCC1 predominating. So this baby we have diagnosed as NKH. So regarding NKH, it is a rare autosomal recessive disorder due to the mutation in the glycine cleavage system. Due to this, glycine accumulates in the brain and the spinal cord. There is defect in the GLDC, AMT, and GCSH gene. We have defect in the AMT gene. Incidence is 1 in 76,000 newborn. There is 2 forms. It is severe form which presents in the neonatal stage with an intractable seizure, lethargy, and encephalopathy, and poor feeding, hypertonia, hiccups, refractory seizure, and encephalopathy. But the attenuated form presents usually after 3 months of age with seizures or easily controlled seizures with expressive language impairment and hyperactivity. This is the CSF glycine concentration, which is in normal, it is less than 20. Plasma glycine concentration is 125 to 450, and the CSF plasma glycine ratio should be less than 0.02. Regarding the CSF sample, we are unable to send the CSF glycine level because it is not available in Kolkata. But we have to take care while sending the CSF sample because it should be free of contamination by blood or serum. MRI along with other features we can see diffusion restriction in the posterior limb of internal capsule, brainstem, cerebellum, and abnormal signal intensity in the basal ganglia that we have seen. Glycine peak we have already discussed. And EEG, we have seen persistent burst suppression, and the molecular genetic test will show mutation in the GLDC, AMT, and GCSH gene. What are the other causes of raised glycine in the newborn period? Are the acute liver failure, valproate treatment, lipoate deficiency, pyridoxal phosphate deficiency, glycine transport defect, but it will have normal plasma glycine. Transient glycine encephalopathy, we also thought of initially that baby may have transient glycine encephalopathy, but the genetic reports are not suggestive. Now we have also in non-ketotic hyperglycemia, there is some topic called ketotic hyperglycemia. This is seen in organic aciduria, where the increase in CSF and the plasma glycine level, but there is normal CSF plasma glycine ratio. Management, there is no formal management of NKH. We have used sodium benzoate, but sodium benzoate do not decrease seizure, but only decrease the seizure, but do not improve the individual's development. Dose is quite high that we usually use in the ICU settings that may cause gastritis, and it is given at 6 doses, the daily doses. Along with that, we can use NMDA receptor antagonists like dextromethorphan, ketamine, or felbamate. Ketogenic diet we can use, and gastrotomy feeding can be given if the child is not accepting feeds. Regarding the prognosis, our baby, after receiving all the reports, we have discussed with the parents, and the parents decided that they will not continue the further support. So we have discontinued the support because they have properly counseled about the outcome of the baby. And regarding the prognosis, symptomatic NKH develop life-threatening bradypnea or apnea due recurring ventilation support in the first week of life that our baby suffered. In the second or third week of life, spontaneous breathing may appear, as appeared in our baby. And following resumption of spontaneous breathing, apnea is unlikely to recur. But the baby will die in the next 2 years because of the raised CSF glycine level. It is that some families elect to withdraw intensive care support during the neonatal apneic phase. There is a topic called attenuated NKH, which develops later, which will have variable developmental outcomes, seizure, and even have cardiomyopathy. Our baby expired at around 3 weeks of age due to type 2 respiratory failure because he was having persistently PCO2 was raised. Thank you. Video.
If there is any question, we can ask sir. So I think we just wanted to show these two cases. The first one was a case of galactosemia. Maybe the time the baby was admitted in the first hospital, where the jaundice, sometimes the jaundice needs to be investigated in a more detailed way. So that's the importance of labor. That's why I wanted to highlight. Unfortunately, we also couldn't do much. We on the day one, from day one, we started to have formulas. We thought it to be a galactosemia, but within 2 days, the baby started to deteriorate, having liver failure and failure to such a high bilirubin level. So this is one. But at this case also, so whenever a baby comes with a neonatal encephalopathy, and once you have ruled out neonatal meningitis infections, so you should not waste a single time. But this time we were very fast. The patients were also very party, the parents were also very cooperative, and so we could send the investigation very fast and we could come to the diagnosis. As Dr. Ghosh said in the beginning, not all the diseases diagnosed will have treatment, but it is very important to do the genetic testing also so that they can be counseled for the next pregnancy. So this is our target, and we at ICH, we are thinking to, with the help of Dr. Shukla ma'am and Dr. Dipanjana, to take it forward. Sir, I would like to thank you. Yes. Yes.
Have you justified the screening test, all the reports? Is there any legal information? No.
No.
It's the reverse.
If we don't do, we can be. So till now there is no government policy, but of course you can, because we are doing this newborn screening in our hospital only in the treatable cases.
Yes.
We are not doing the extended till now.
These children.
No, we were doing this distributed in the NICU, but we are now planning to do it in all babies. These 4 conditions. These 4 conditions are preventable causes. So in that, if we don't do, we can have some.
Thank you, sir, for the it's a good question. Actually, so the answer to this question is we can't force the parent. What you are asking. So if you are telling in US, it is mandatory means the parents can't do. Here, if you are telling, you have to counsel the parents that you need to do this test. And if the parents said, I don't want this test to be done in HIV. Even if it's for free, even if it's for free, the parents don't agree. That's what is meant by mandatory. And if it's mandatory, it's government mandatory. Government has told it has to be done. It's just like what's the vitamin supplementation wasn't there before. Now at birth you are giving that. So it is as per rule of immunization. You are doing that. It's government policy to do that. That's the difference in the government policy. That's why we want the government policy for newborn screening. Unless we don't have it, and each parent, each child, we have to take part.
So I just example which is a bit different from this. You all are aware of prenatal screening, right? Down syndrome screening. That's also not mandatory. But right now, a lot of legal cases have been filed saying that if a screening was there, why was this not offered? Because as a layman, I do not know that screening
So
is.
you have to offer it to that
So
spec.
offering is our duty, but it is, we cannot force them to do it, number one. Number two is that if they decline, please, make a note that they have declined.
Yes.
Submit, because otherwise it might be legal trouble. There are documents in other states that exist that it's mandatory. So even in these prenatal screening, what is happening is that they are saying that it is mandatory in India and certain other places, so why was I not offered? As a layman, I did not know that this testing is.
Yeah, that's the problem.
This
Because when I
exists that we are
outside, some schools they are doing it, some are not doing it, so that's pretty one.
So that is treatment you need to offer, as sir said, it's not mandatory, so we cannot force, but the information has to go out. And that has to be documented somewhere in your clinical notes that it was offered, it was accepted, or it was rejected.
The same thing is for COVID vaccination.
Yes,
You can
yes.
reject it. You can say, I don't want. But nobody can force it. But is that in the document? So just for the peak, this I just wanted to emphasize. Also, when I was hearing that, I wanted to tell that please publish your findings as far as possible, because unless we publish it, 10 years down the line, it is not documented. And just presenting it in a CMA, there's no value for it. Like I'll give you an example, like when we published this work on organic asturia in 2011, it was just published in a journal called Indian Journal or Biochemistry Normal. It was just an upcoming journal. It was trying to get PubMed indexation at that time. So 20 years down the line, now this paper, our work on organic asturia, I am so proud to say that it has been cited in Nature, Journal of Chromatography, and recently in CCL. So when you publish it, maybe you think that immediately it doesn't have any impact. But maybe if it has scientific work, the work will come maybe 20 years later. Please publish your studies also.
This is a baby having hiccups.
So the clue to this baby was a encephalopathy and a persistent hiccup, which is a very typical of NKH. Okay. So there are certain clues to some of the IM. Most of them may present in a very stereotyped way because they may mimic infection, they may mimic hypoglycemia. But some of them has a very unique features. So this was very classical, and they present with the frequent appears and bradycardias also. So it's very always. So I would like to what do you want?
Panchana, you can give the vote of thanks.
Yeah, Dr. Shabana and Dr. Joyce.
Thank you everyone for attending.
So we are Dr. Shabana.
Shabana was having so we have a whole team of intensivists for taking care of the newborns. And I'm sure that everyone's feeling will take a different meaning from today onwards. At ICS, since we operate in biochemistry, now we are enlightened. So thank you to the NICU team. Thank you to the Panchana from my side for organizing this so well. Thank you to read the book. Our sponsors.
I really thank everybody for making our time on a busy day. And I thank the administrators body of ICH, and especially Dr. Shilpa Basu for involving me in this seminar. And at the outset, I really, my heartfelt thanks to the organized, the people who made it possible with the financial support. Strand gave us some support. Medgenome, Unipath, we also have Pathline, and also very graciously we have HDFC also supporting us for this program. So I really thank you, thank all of you. Please do have lunch. Lunch is there waiting outside, so please take your lunch packets. And until next time, head off. Bye.
Yes. Thank you.
Yes, sir. Just
One of the how solvent for the